Welcome to the deep dive. We're really thrilled to have you joining us today
Yeah, thanks for being here.
because if you spend any time, tracking medical procedures or endoscopic techniques, you quickly realize that the space between just seeing a problem and actually diagnosing it.
Right. That's where the real work happens.
Exactly. That's where the clinical heavy lifting is. We hear terms like cytology thrown around all the time,
Constantly, yeah.
but the actual mechanical reality of it, the step-by-step choreography required to safely get viable cellular material out of a patient, it rarely gets the spotlight it deserves.
It's a completely hidden ecosystem.
Yeah.
I mean, we focus so much on the high definition imaging of modern endoscopes, but when it comes time to actually interact with the tissue, it all comes down to this highly synchronized teamwork.
And some surprisingly analog engineering,
Completely.
which is exactly what we're getting into today. We're grounding this deep dive in a really fantastic, highly specific clinical resource.
It's a great one.
It is. We're looking at a YouTube video transcript from the channel of Dr. Gautamakula S. Raju. Specifically, a video titled HCC 1475-18 Cytology Brush.
Right.
And it is just this remarkably clear, pragmatic breakdown of the mechanics, the clinical application, and the diagnostic workflow of the cytology brush during an endoscopy.
And what makes this source so valuable is its grounded approach. It doesn't just abstractly discuss cytology. It really walks you through the physical reality of the tool.
Yeah, it demystifies it.
Exactly. It breaks down that tactile interface between the clinician, the assistant, and the patient's mucosal tissue.
Okay, let's unpack this, because the source doesn't just hand us the tool out of nowhere. It sets up a very specific clinical scenario to show us why we'd need it in the first place.
Right, the patient case.
Exactly.
Right.
So we're looking at an elderly gentleman. He has a history of asthma, and as is pretty common with chronic asthma management, he's been taking steroids.
Right. And anyone familiar with long-term corticosteroid use knows we're immediately dealing with a degree of immunosuppression, either localized or systemic. And that clinical background is just vital context for what happens next.
It really is. So he presents to the clinic with some concerning primary complaints. He's got dysphagia,
Difficulty swallowing.
right, and retrosternal discomfort, that constant troubling pain
Yeah.
right behind the sternum.
Yeah, that's alarming.
And when a patient with his specific medical history presents with difficulty swallowing and chest pain, you don't just guess at a diagnosis. You need visualization.
You have to get eyes on the esophageal mucosa.
Exactly.
So the clinical team proceeds with an upper endoscopy, and what they find immediately validates his complaints.
Yeah, they see it right away.
The endoscopy reveals extensive esophageal candidiasis. The source describes the doctor visualizing these very distinct yellowish plaques coating the mucosal lining of the esophagus.
It's a really striking visual finding. Basically, opportunistic candida blooming in the esophagus, likely secondary to that prolonged steroid use we mentioned.
Right. What's fascinating here is that we've hit a critical clinical crossroad. Seeing those yellowish plaques is one thing, but confirming the pathology is another entirely.
Visuals just aren't enough.
Exactly. The source points out that at this exact moment, the endoscopist has to make a choice about tissue acquisition. They need physical evidence to send to the lab for a definitive, documented diagnosis.
And they essentially have two primary avenues here, right?
Right. They can deploy biopsy forceps, or they can opt for the cytology brush.
And for this deep dive, we are following the exact path of the source material and focusing entirely on that second option, the cytology brush.
It's the right tool for the job here.
I find it so interesting that for superficial friable lesions like these candida plaques, a brush is often the superior choice.
Yeah.
You're maximizing the cellular yield over just taking a localized bite with a forceps.
Exactly. But the brush itself isn't just a simple stick with bristles on the end. The engineering is highly specific.
It has to be. You're trying to perform a delicate scraping maneuver at the end of a meter-long flexible tube.
Right. Inside a person.
Yeah. And the design of the handle mechanism is what makes that possible. The source breaks down this anatomy beautifully. It's built entirely around precise, one-handed control for the assistant.
So let's trace the mechanics of that handle for you. At the very proximal end, the end closest to the assistant, you have a thumb ring.
Okay,
And just distal to that, along the shaft, is a slider.
got it.
The intended grip is very deliberate. The assistant's thumb goes through the ring to anchor the device, and the slider is grasped firmly between the forefinger and the middle finger.
So it relies on the exact same ergonomic principles as a traditional syringe.
Precisely. By anchoring the thumb and using the forefinger and middle finger to manipulate that slider, the assistant gains incredibly nuanced linear control over the distal end of the catheter.
So every millimeter of movement on the slider in their hand
Yeah.
directly correlates to the deployment of the brush deep inside the patient.
Exactly.
And we should definitely clarify what the slider's actually doing.
Yeah.
'Cause the bristles aren't just hanging out in the open, right?
No, not at all. The working element of the cytology brush is housed entirely within a flexible plastic outer sheath.
That plastic sheath is really the unsung hero of the whole device.
It absolutely is. When the assistant unpacks the brush from its sterile envelope, whether it's paper or plastic packaging, the device is in its default closed position.
Right.
Meaning the slider's pulled back toward the thumb ring, and the brush itself is fully retracted safely inside that plastic casing.
So pushing the slider forward, away from the thumb, pushes the brush out of the distal end of the sheath.
Right.
And pulling the slider back, retracts it.
Exactly. It's a very simple push-pull mechanism.
But the pre-procedure protocol surrounding it is rigid. The doctor doesn't just take the package, rip it open, and feed it into the endoscope.
Definitely not. There is a mandatory pre-flight check, and the source makes it extremely clear that this falls squarely on the assistant.
Before the endoscopist even touches the device.
Right. The assistant has to test the slider's action. They will actively push the slider forward and pull it back a couple of times.
Just feeling for any resistance.
Exactly. Any mechanical catch in the wire. They're ensuring the bristles deploy and retract smoothly.
Because if that assistant forgets the final step of that test sequence, they're setting up a potential disaster.
Oh, yeah. The absolute golden rule here, according to the source, is that the brush must be handed over to the endoscopist in the strictly closed position.
It is entirely non-negotiable.
Completely. Because if you hand over an open brush, or even if the slider just gets bumped forward during the handoff,
You compromise the entire procedure.
yes. First, you risk contaminating the sterile bristles with whatever environmental flora is in the room. But more critically, you are about to pass this device through the biopsy channel of the endoscope.
Right. If those bristles are exposed while you're advancing the catheter down the working channel, you're just scraping the inside of the endoscope itself.
Exactly. You'll destroy the bristles, you'll collect artifact material from the scope, and you basically ruin your diagnostic sample before you even reach the patient's tissue.
So you really need the smooth, blunt, atraumatic tip of that plastic sheath leading the charge.
Yes. It protects the working channel of the scope, it protects the integrity of the brush, and ultimately, it protects the patient's delicate esophageal mucosa as the catheter is navigated down into position.
Okay, so the handoff is successful. The slider is pulled back, the brush is safely housed, and the endoscopist takes the catheter.
Right.
Here's where it gets really interesting, because the procedure completely transitions from a mechanical preparation into this exercise in blind trust and strict verbal choreography.
It's all about communication now. The endoscopist feeds the closed catheter down the biopsy port. They're watching the high-definition monitor, tracking the progress of that plastic sheath as it emerges from the distal tip of the endoscope right into the operative field.
Okay.
And they navigate that blunt tip directly adjacent to the yellowish Candida plaques we discussed earlier.
But the dynamic here is wild. The doctor has the visual, but they don't have control of the handle. And the assistant has their hand on the slider, but they're completely blind to what's happening inside the esophagus.
They're operating purely on verbal commands.
It requires total synchronization.
Mm-mm.
So once the sheath is perfectly positioned against the lesion, the endoscopist simply says, open.
And the assistant immediately pushes the slider forward.
No hesitation.
None. On the monitor, the endoscopist watches the brush emerge from the plastic casing directly onto the target tissue. The instrument is now live.
And now the tactile work begins. The endoscopist takes control of the physical scraping motion.
Right. They manipulate the entire catheter, moving it in and out of the working channel in these short, deliberate strokes.
They're actively brushing the mucosal surface,
Yeah.
aggressively sweeping those bristles across the yellowish plaques to harvest the cellular material.
It is an abrasive action by design. They have to liberate those fungal organisms and the reactive epithelial cells from the mucosal wall so they adhere to the bristles.
And they just continue this brushing technique until they're clinically satisfied with the visual tissue disruption, right?
Yeah, until they assume they have a good cellular yield. And once they determine they have an adequate sample, the communication protocol kicks back in.
The endoscopist holds the catheter completely still.
Crucial step. They hold it still to avoid losing any material, and they issue the second command. Close.
and the assistant pulls the slider back toward the thumb ring. The brush, which is now heavily loaded with the diagnostic specimen, is drawn safely back into the protective plastic sheath.
It's locked away.
It's such a critical moment. Because if the endoscopist starts withdrawing the catheter before the assistant has fully retracted the brush,
You risk shearing the sample right off on the edge of the endoscope's working channel.
you just lose the diagnostic material you just fought to obtain.
Exactly. The coordination has to be flawless. But once that brush is confirmed closed, the assistant smoothly pulls the entire catheter assembly out of the biopsy port.
The extraction is complete. And for the patient, that specific intervention is over.
Right.
But as the source highlights, the workflow for this specimen is really just getting started.
Oh, definitely.
The handoff from the endoscopy suite to the pathology lab is incredibly meticulous.
This is where we see how highly valued this cellular material really is. The catheter is out, but the sample is still trapped inside the sheath.
Right.
So the assistant immediately takes over to prepare the slides. They advance the slider one last time, exposing the sample-loaded bristles.
And the source describes the smearing technique in detail here. The assistant takes a clean glass slide, frequently two, depending on the institutional protocol,
Right?
and they physically transfer the material. They press the exposed bristles against the glass and drag them from one end of the slide to the other.
They're striving for an even, thin cellular distribution across the glass.
Right, they're literally rolling and smearing the bristles to offload as much of that harvested tissue and fungal material as possible.
And this immediate smear creates a direct, unadulterated cytological preparation for the pathologist to stain and review.
Once those slides are smeared, they are immediately placed into a dedicated specimen container.
Often holding a fixative.
Yes, as the source points out, this container usually holds a specific liquid fixative or preservative. That's to arrest cellular degradation and maintain the morphological integrity of the cells during transport.
Getting the sample into the fixative quickly is paramount. Cytology specimens are prone to rapid air drying artifact.
Which ruins them.
Exactly. It can completely obscure the cellular details and render the slide non-diagnostic.
But the protocol doesn't stop with the smeared slides. And this is the detail in Dr. Raju's transcript that I found absolutely brilliant regarding diagnostic redundancy.
Yeah, this is a great point.
Because you'd assume that after vigorously smearing the brush across two glass slides, the physical brush is considered medical waste and just gets discarded.
That would be the intuitive assumption. But in cytopathology, you never leave potential diagnostic material on the table.
Never.
The assistant actually takes a pair of heavy scissors or wire cutters and physically severs the tip of the catheter.
They literally amputate the entire bristled head of the brush.
Exactly. They cut the brush tip off entirely, and they drop that severed head into a secondary specimen container.
Which is also filled with a cytologic preservative fluid.
Yes.
So the pathology lab is receiving a dual modality package. They get the pre-smeared glass slides in one container, and they get the physical severed brush tip swimming in preservative in another. Both are sent out together.
This raises an important question regarding optimizing diagnostic yield. I mean, why go through the labor of creating the direct smears if you're just going to send the whole brush anyway?
Right.
It comes down to giving the cytopathologist every possible advantage.
It's essentially a fail-safe mechanism. Because no matter how aggressively you smear that brush on the glass, you are going to leave cellular material trapped deep within the matrix of those bristles.
Precisely. The direct smears provide an immediate, pristine snapshot of the tissue exactly as it was pulled from the mucosa.
Okay.
But when the lab receives that severed brush tip in the fluid, they can process it using techniques like cytocentrifugation. Yeah, they will actively wash and vortex those bristles in the fluid, dislodging every single remaining fungal spore or atypical epithelial cell.
And then they spin that fluid down to concentrate the cells and create additional highly dense slides.
Exactly. It ensures absolutely zero diagnostic material is wasted.
Because when you're dealing with potentially life-altering diagnoses, maximizing that cellular yield is the difference between a definitive answer and an inconclusive report that requires a repeat procedure.
Nobody wants to do the procedure twice.
Exactly. And while the source anchors our understanding of this tool using a case of esophageal candida, it makes a very clear pivot to highlight the much broader, higher stakes applications of the cytology brush.
It's vital to recognize that this isn't just a tool for identifying fungal plaques.
Yeah.
The mechanical simplicity of the brush, its ability to navigate tight spaces, deploy, scrape, and retract, makes it an indispensable frontline instrument in oncology diagnostics.
Yeah, the transcript explicitly details its use in confirming severe malignancies. The exact same handle, slider, and sheath mechanism is deployed to diagnose esophageal cancer and gastric cancer.
Right. When an endoscopist visualizes a suspicious ulcerated mass in the stomach lining, the cytology brush is often deployed alongside traditional biopsies.
Just to ensure they capture malignant cells that might be sloughing off the surface.
If we connect this to the bigger picture, the source points out an even more technically demanding application: the biliary tract.
That's a huge shift.
It is. You will frequently see the cytology brush utilized during ERCP procedures to diagnose cholangiocarcinoma cancer of the bile ducts.
And that is a massive leap in procedural complexity.
Definitely.
I mean, navigating a catheter through the stomach past the duodenum and feeding it up into the incredibly narrow, tortuous pathways of the biliary tree.
Incredibly difficult.
Deploying a brush inside a bile duct to scrape a stricture for malignant cells requires an entirely different level of precision from sweeping the wide-open lumen of the esophagus.
It's one of the most challenging environments in endoscopy. And the fact that this fundamental brush design is trusted to extract diagnostic tissue from a bile duct stricture speaks volumes about its reliability.
Yeah.
In biliary strictures, traditional biopsy forceps often just can't reach or manipulate effectively within the duct.
They're too bulky.
Right. The flexible cytology brush is sometimes the only viable method for acquiring a tissue diagnosis without surgical intervention.
Which brings us to a crucial consideration here for you: patient safety.
Always.
We're talking about aggressively scraping inflamed esophageal tissue, ulcerated gastric masses, and delicate bile ducts with an exposed wire brush.
It sounds inherently traumatic.
It really does.
Yeah,
Yet the source provides a highly reassuring metric regarding the risk profile.
it does. Despite the invasive nature of the procedure and the physical abrasion required to harvest the cells, the source explicitly states that the use of the cytology brush is considered very safe for the most part.
There are exceptionally few adverse events or severe complications associated with the brushing itself. You might see some minor self-limiting mucosal bleeding at the scrape site, but significant perforations or massive hemorrhages directly attributable to the brush are incredibly rare.
And that's really a testament to the meticulous design of the tool.
Right.
The atraumatic plastic sheath, the specific gauge and flexibility of the bristles, and, crucially, the strict adherence to the operational protocols we discussed.
The safety profile is entirely dependent on that closed sheath insertion and the precise coordinated communication between the endoscopist and the assistant. It all circles back to the choreography. The engineering mitigates the risk, but the human execution ensures the safety.
Exactly.
Let's briefly retrace the clinical arc we've covered today based on Dr. Raju's breakdown. We started with the macroclinical picture: an asthmatic patient with a history of steroid use, struggling with dysphagia and retrosternal pain.
Which led to the visual identification of opportunistic Candida plaques, forcing the decision to acquire tissue via cytology rather than forceps.
We dissected the ergonomic ingenuity of the handle, the thumb ring, and the slider, and analyzed the critical pre-procedure testing by the assistant to ensure the brush is housed safely within its plastic sheath.
We followed the exact procedural sequence down the working channel, emphasizing the blind trust and rigid verbal commands required to safely deploy, scrape, and retract the bristles without compromising the endoscope or the patient.
And finally, we tracked the specimen's journey out of the endoscopy suite. We looked at the immediate creation of direct smears and that highly redundant, brilliant protocol of amputating the brush tip into preservative fluid.
Right, to guarantee the cytopathologist has every single cell available for analysis.
We've seen how this seemingly simple mechanical tool scales from diagnosing a fungal infection to identifying life-threatening malignancies in the esophagus, stomach, and bile ducts, all while maintaining an exceptional safety profile.
It really highlights how the most consequential moments in medicine often rely on basic mechanical principles executed with absolute precision.
It's a fascinating intersection of engineering and pathology. And as we close out this deep dive, I want to leave you with a final visual to consider. Think back to that secondary specimen container leaving the endoscopy suite.
Right.
Picture that severed brush tip submerged in a vial of clear preservative, making its way to the pathology lab. Consider the microscopic reality trapped within that tiny matrix of bristles.
It's an entire world.
It is a physical, suspended snapshot of the patient's internal mucosal landscape. It's incredible to realize how much diagnostic weight, how many definitive answers regarding a patient's survival, their treatment plan, their entire future is quietly riding on the successful harvest of just a few thousand microscopic cells tangled in a piece of severed wire.
It's true.
It fundamentally changes how you look at the physical tools of diagnostics.
The macro decisions in medicine almost always hinge on the micro evidence. It's a profound realization.
It truly is. We want to thank you for joining us today as we navigated the intricate, hidden mechanics of the cytology brush. Keep examining the details, keep questioning the processes, and above all, stay curious. We'll catch you next time.